transesophageal echo.
Yeah.
So how would you manage that, and who is going to do it in the non-cardiac setting? And
well,
this links us to the last presentation, I believe.
I have to say, I have to say, I agree with the opinion paper that says that there should be a cardiac anesthetist or a cardiologist that is familiar with LVAD, not just with echo, but echo in LVAD for these patients. So if you have complications, the first thing I would do is probably put down a probe to check exactly the interaction between the two ventricles, to be honest with you. That's actually just happened to me recently when blood transfusion just led to a suction cascade, and that was dealt with inotropes under echo vision.
I think I'm one of the rare anesthetists who actually experience cutting through the drive line, fortunately in the cardiac anesthesia setting. And our surgeon started to rewire the different, I think there are 12 wires. I offered a bottle of champagne, if that worked, and indeed worked. In response to that, the company actually now has a connector which allows this to do more rapidly. So I think every non-cardiac center should have that connector. Thank you.
So thank you, Dr. Mondino. It's now a pleasure for me to introduce the next speaker, Fabio Sangalli. I don't think I need to introduce you, Fabio, who is going to talk on transesophageal echocardiography for non-cardiac anesthesiologists. What you need to know. Please.
Thank you, Fabio. And thank you, Nandi, for the question you gave to Michele, because it's leading my way. So I have just one thing to disclose, which is, unfortunately, as you can see from the title, this won't be a very practical clinical presentation. I'm sorry about that, but I'll try to manage, and I hope you do too. I will talk about what is critical care echocardiography, the advantages of TOE or TE, as you want to spell it, over TTE, if any, and what we should do to implement a critical care echo program. So we've started to talk about critical care echo in the early 90s, and published papers on the topic are increasingly over time. And we came to the to the conclusion that echocardiography is not anymore a domain of cardiologists in their echo labs. Cardiac anesthetists started to master advanced echo techniques in the cardiac theater, but nowadays more and more specialists from different backgrounds are using echocardiography on a daily basis. So echocardiography has become as a first-line tool, as recommended by international intensive care medicine guidelines. However, it has become more and more a diagnostic tool. It still is, also in the critical care environment, a diagnostic tool, but every day we use it more as a monitoring tool. So critical care echo is a monitoring tool. It not only is as reliable as other monitoring tools, but it also, by giving you a clear view on function and on anatomy, it gives you the ability to discriminate between different hemodynamic conditions that might give similar numbers from standard traditional monitoring. However, all the guidelines that I'm aware of, it goes too fast, sorry. All the guidelines I'm aware of consider TE only as part of advanced critical care echo education. We all know that we use transthoracic echo more than TOE, especially in the cardiac anesthesia environment, but also in general intensive care and anesthesia. This might be because we all have surface probes on our echo machines, while the TOE probes are often locked in the echo lab or are only in the cardiac ICU. It might be because although literature indicates that TOE is easier than TTE to manage, but there's a common belief that you must be clever, you must be smart to do TOE. We can't forget that although complications are very rare, but it is a little bit more invasive than TTE. And in fact, if you remember the pyramid of education in echocardiography, in critical care echo, the base level does not include transesophageal echo. So we've seen that training in TE or TOE is considered as part of advanced training. And it is also a common belief that TE is, or better, that echo in general is in a certain degree operator dependent, and TE is less operator dependent than TTE. Just a brief comment on that, because I'm not really aware of any tool we use in our daily practice that is not, if you want to call it so, operator dependent. I hope, at least I hope so, that my Cormac grades 1 will be more than a first year trainee. An expert in mechanical ventilation will manage the patient better than one who is not so skilled. So I'd better talk about competence more than operator dependency. What I mean is that if properly trained, the degree of operator dependency of echocardiography is not so bigger than any other technique. And this is for an additional reason, because if it might be not so easy to obtain adequate images, it is still more complex to interpret and to insert them into the clinical management of the patient in an adequate manner. So we have an increasing level of competence based on the training, based on the level of training. Of course, basic training does not allow to pose a diagnosis. It's not diagnostic. It's only meant as a monitoring tool. Whereas as we progress along the scale, we can reach advanced levels of training. What is becoming more and more evident is that you don't need an extremely complex or advanced training for basic TOE. There are many papers published in the past 5 or 6 years regarding training in basic TOE. And this one was one of the last that I saw. It was done on critical care fellows with a basic training in TOE. And in 1 patient in 3, roughly, critical care fellows-led examination led to a new or unexpected finding, and in the majority of patients, this led in turn to a modification of management. However, even if the recent guidelines suggest that every ICU is able, every general, ICU, not cardiac ICU, is able to perform TOE, still we have only an indication to include TOE training in advanced critical care echo training. I see a problem in this because maybe the advanced echocardiographer is skiing on the slopes, or maybe is at home at night or during the weekend. But we have a number of conditions where TOE can make the difference in clinical practice. And these are, I think, the more common conditions that we face every day in the emergency department or in the general ICU, for instance, in cardiac arrest. We can easily discriminate between cardiac rhythm. I know we have the ECG trace, but if I ask you what, apart from that, it's written above the image, but if I ask you what cardiac arrest rhythm is this one, I think it will take you 1 to 2 seconds to say that this heart is fibrillating, okay? Same thing for the other one. In case you're wondering, the motion is just CPR being performed. Another important issue, maybe we are resuscitating a patient for half an hour, then the patient is never getting a return of spontaneous circulation, and we can prevent ourselves from being inaccurate. You can see here that with TOE, we can see that we are performing the CPR incorrectly. We are compressing only the right ventricle, the aortic valve is not opening, and so we are pretending to do CPR, but we are not actually. Same thing in this other picture. You see this was a mechanical chest compression device, which was compressing the LVOT instead of compressing the LV, and so the aortic valve was compressed, was not opening, was not ejecting, and just by adjusting the position of the device, CPR could be optimized. Another indication, I'd say a mandatory indication for ECPR, for transesophageal echo is ECPR. If you're doing ECPR, not only it allows you to pose the indication to ECPR, but it's also fundamental in helping cannulation. Here you can see a guide wire in the inferior vena cava, which is against the interarterial septum. It's not progressing into the superior vena cava, and with echo you can optimize the insertion of the guide wire. Same thing to confirm the positioning of the guide wires in the aorta, and to troubleshoot cannulation and to solve problems as soon as they occur. Another aspect where transthoracic echo has limits where that TOE doesn't have is in chest trauma, in closed trauma. We all know that most of lesions occur in regions that are not easily investigated with TTE, namely the aortic isthmus and the descending aorta. And of course, you can see here a short axis of the descending aorta, long axis at the same level. We can easily, with a limited training, we can easily discriminate a lesion that wouldn't be visible with TTE. So I admit I have larger, bigger dreams, but a small dreams that I have is that in the near future, TOE will be included even in the more focused and basic level of echo training. We don't need a very long training. You know what already happens for the FEEL or FATE or for the UK-based colleagues for the FICE protocols. We have a limited number of transthoracic views in order to discriminate life-threatening problems, and we can do the same. This is what I normally use in daily practice, a limited number of 3 basic views: a middle esophageal 4-chamber view, a middle esophageal long axis view, and a transgastric short axis view. These together allow to discriminate most of the, sorry, too many animations, sorry. These allow to discriminate most of the life-threatening conditions that I can encounter in the emergency department or in the perioperative period. And in the setting of trauma or ECPR, it is advisable to add 2 additional views, a bicaval view and a descending aorta view, in order to exclude significant lesions or to guide the cannulation in the setting of ECPR. Does this work? I have my gut feeling, but added to this, I think it was 1 or 2 months ago, I saw this paper. This was a 1-day course on focused TOE, and it led to the conclusion that a 1-day course was sufficient, was enough to obtain adequate and reproducible results as compared for a limited and focused indication as compared to longer courses. And what added, pardon me, an added value to the course was the use of a mannequin. of TOE simulation. This was increased even more the efficacy of the course. So in 2013, the American Society of Echo, we are all aware of, sorry, it goes on its own. We are all aware of all the comprehensive echo accreditation programs that are available around the world. In 2013, the ASE, the American Society of Echo, firstly published a new guideline on basic TOE. You can see here the citation of the paper. And it's meant to give a limited number of views and a limited diagnostic capability. We ran a course, just some self-promotion, we ran a course in the past few days here at the SMART meeting on basic echo. As you can see, we had a large use of simulators. And it's a little bit more complex than the protocol we saw before. It's 11 views. It's meant to discriminate the cardiac causes of hemodynamic or ventilatory instability. And in case you want to climb up to the higher level of the education in critical on transesophageal critical care echo, we still have the comprehensive accreditation of which is not only more complex in terms of views, but also in terms of techniques that are applied. For instance, Jens Fassel talked to us about strain, 3D, and so on, and these are all included in the advanced certification. So this is theory, quite boring. However, we should be able to do that in our daily practice. So how can we do it? Briefly. Of course, we need to, nothing is given as a gift. We have to study, we have to get a formal training, but we also need resources. We have to do simulation training. We have to do less and less being a relatively invasive maneuver, less and less practical training on the patients, but we should come to a point where we have to insert our first probe in the patient and go on training on the patient. And to do this, we need, as I was mentioning before, resources. Not only formal training and education, not only control of what we are doing by implementing a quality improvement protocol, but we need online simulators nowadays. Online simulators which are available. I will show you one in the next slide. And also I-Fi mannequin simulators, which are still quite expensive. They roughly cost 70,000 to 100,000 euros per mannequin, so they are not easily available in every institution. One of the possibilities is to rent those mannequins for courses and for training. But we also have to set standards, general standards and institutional standards in every hospital. It is not, I don't believe we are allowed anymore to do it in a, let's say, how it comes. We have to standardize things, to standardize protocols, and also to check and to audit what we are doing. Here is my only conflict of interest in this presentation, as a friend of mine, Massimo Ineri, developed this online simulator. Mass is working for a few weeks, I believe, then he's moving back to Europe. He's working in Toronto, where he developed this simulator. I suggest, if you don't know it already, that you visit it because it's worth it. Then, for those of you who have never seen it, we have a number of simulators. I've tried these two ones. This is a British simulator, the Artworks one, and the other one is the one we used during the last course. Is originally Canadian simulator. Now it's also available in Europe. Of course, they are not real patients, so they have limitations. If I were planning an advanced course, I don't think that I would need them so much, but for basic courses, and I can tell you, even based on the feedback forms from participants in the courses, the online simulator gives a plus, and as we saw in the previous paper, it also gives an improvement in the diagnostic capabilities of the attendees. Last point is that even for advanced practitioners, but even more important for basic practitioners, you can base your conclusions only on your own experience. So it is important that in every institution we have experts, we have mentors, we have a supervisor that can help and check the progress of younger and less experienced colleagues. So given that it is not easy to achieve competence in critical care echocardiography, as I already told you, we have two problems. The first one is to obtain images, and in this aspect, unfortunately, let me say unfortunately, TOE is able to give us better images. It's easier. Anyone, after a few tries, can have optimal images. However, to translate those into good clinical practice, into an effect on the outcome of the patient, we have to interpret, and this requires a little bit more of experience. And in fact, one of the main limitations to training and certification, this is, as I left the title of the table just to show you that even for the more basic courses, the FICE course is a one-day transthoracic course. They still have limitations in obtaining the certifications for the lack of mentors and trainers. And so, as an editorial last year concluding, we should still have to bridge the gap between enthusiasm for echo, for what echo can do, and for the real limitation that we still have in implementing it in our daily practice. Thank you.